Okay, thank you everyone for being here. Today is a webinar in part of the series for the Maryland Model Analytics Project. This project was an initiative by CRISP that set out to answer or evaluate specific aspects of the total cost of care model and the care transformation efforts within the state. We have contracted with AIR, who is here today to report on their evaluation of year one of the Care Transformation Initiative. They also produced a wonderful report on CTIs from a pre-implementation standpoint, and that can be viewed on our learning system, which I'm happy to drop the link down there. Max Scrow will be leading this and presenting on this. I do want to mention that while this is a wonderful analysis, the final results of the CTI program actually won't be available till the end of April, and the HSCRC will be doing a full report out on sort of the official results. But this is a wonderful evaluation and perspective on sort of year one from the data that was available at the time. So with that, I'm going to hand it over to Max, and you can go ahead and get started.
Great. Thanks so much, Jessica. It's good to be with everyone this afternoon, and looking forward to just giving a brief presentation on the evaluation we conducted over the last few months on year one of the Care Transformation Initiatives program. So as far as what we'll get to today, we'll give a brief overview of our evaluation, the data sources and methods that we used, our key findings and conclusions, and then we'll have some time at the end for a Q&A. So this information will probably be familiar to most of you, but if there's anyone on the call today who is less familiar with the CTI program, it was established by the HSCRC to meet the requirements of the total cost of care model, while still allowing hospitals the flexibility to define their own episodes of care and test interventions to determine whether they reduce costs. Hospitals that conduct CTIs can earn additional payments by achieving savings for their defined episodes during a performance year. And to fund these additional payments in a cost-neutral way, the state will reduce payments to all hospitals, including those that do not participate in the program. So the CTIs in year one were grouped into thematic areas based on the similarities of the clinical interventions involved in the CTI. The settings where the triggering event occurred, for example, hospital or primary care practice, and how the patient populations were defined. So the thematic areas included were care transitions, community-based care, emergency care, palliative care, and primary care. And you'll see these thematic areas referenced frequently in this presentation. It was the main way that we broke out the different types of CTIs to conduct our analysis. So an overview of AIR's evaluation and our involvement in this program. As Jessica mentioned, we evaluated the CTI program in two parts. Part one of the evaluation was conducted in the pre-implementation period. This evaluation focused on the way hospitals design their CTIs, areas of spending that were and were not included in CTIs, how CTIs align with published research on care transformation, and the extent to which CTIs address socioeconomic status and race and ethnicity. And as Jessica mentioned, that report is available if anyone wants to take a look. So part two, which is the part of the evaluation that I will be focusing on today, is follow-up from the first complete year of the CTI program, which ended in June 2022. This evaluation looks at which CTIs are achieving savings and includes feedback from hospital participants. So representatives from hospitals that were involved in the CTI program, and it offers recommendations on how the CTI program could be improved or expanded. Just a quick overview of the data sources we used and the methods we used to conduct this analysis. We used a mixed methods approach, which means that we used both quantitative data, so data from CRISP and the HSCRC on the costs and target prices for each CTI that were active during the first performance year. And as Jessica mentioned, this analysis was conducted independently by AIR in February of 2023 using the data that was up to date at that time. But it is not the final data that that HSCRC will be using to kind of officially calculate the costs and savings of the CTI program. So do want to add that disclaimer that the results here are representative of sort of a point in time in February, but are not considered the official program results. And the data that the specific questions and analyses that we looked at included the total cost of each CTI compared with the total target cost, the total per episode cost of each CTI compared with the target per episode cost, comparison on the number of episodes for each CTI during the performance year and at baseline, the average CTI total cost compared with target cost for CTIs that identify as having an SDOH focus, and the average total cost compared with target total cost by thematic area. So the second part of our mixed methods evaluation was using qualitative data, which means surveys and key informant interviews. We conducted an online survey some of you may have participated in. It had 12 questions and simply asked participants to share their perspectives during the year one phase. We received 21 responses to the survey. And the key informant interviews were 45-minute interviews with representatives from 7 hospitals. This was just a more in-depth look at what each hospital's experience was throughout the CTI program, how their implementation process went, and any successes and challenges from the first year of the program. Okay, so moving on now to the key findings. CTIs during the first year of the program covered 243,000 Medicare fee-for-service beneficiaries, which represent nearly a quarter of the approximately 1 million beneficiaries enrolled in Medicare Parts A and B in any given month. And looking at the breakdown by thematic area, we see that care transitions and primary care represented the bulk of the CTIs, and they were nearly 75% of the first year CTIs between those two thematic areas. We also took a look at the number of episodes available, both at baseline and during the performance period. We took the average, minimum, and maximum, and we can see that the range between the baseline and the performance period is roughly similar across all thematic areas, though there is some difference between baseline and performance period, and this variation could reflect differences in the patient populations and the length of episodes. Okay, so we also looked at the target price and the change in the target price, the preliminary target price and the final target price. And the variation between these depends on the patient complexity, the care needs, and the types of costs that hospitals chose to include in the episode. So the final target price for each CTI are updated from the baseline period to account for risk adjustment and inflation. We see that there are small differences in the target price between the preliminary and final calculations. We note that this there could have been a fairly significant change in the case mix just due to the COVID-19 pandemic. And COVID-19 is kind of an external influence on many of the findings throughout the CTI program. Just a kind of step back now to look at the hospitals participating in the program. We see that almost all hospitals are participating in the CTI program. Most were motivated to participate by the potential to earn savings. And many hospitals were also interested in continuing work that they were already engaged in and to be formally evaluated on that work, and also to avoid potentially losing money by not participating in the program. About half of respondents said that their CTI was intended to address an area of high spending, and the other half said that this was not the main goal of their CTI. So looking at some of the financial results, on average across all CTIs, the mean total costs were in excess of target total costs by approximately $1 million. We saw that CTIs related to primary care were shown to perform closer to target costs on average compared to other thematic areas. And if you look at this table, you can see a distribution of the minimum and maximum total costs in excess of target costs. And so, for example, in primary care, you can see that the final total costs were kind of the smallest compared to the target total costs across the other thematic areas. We also see that there was a wide variation here. For example, in care transitions, the variation went from 17 million over the target total cost to 1 million below. Looking specifically at those CTIs that had lower costs than their performance target, we see that 33 out of the 104 CTIs did have lower costs and generated savings. These CTIs represented about 1/3 of all CTIs and included all thematic areas. So there's not necessarily a scenario that one of the thematic areas failed to produce savings at all. You can see the percentage of CTIs with cost savings in the final column. A few to note, the palliative care had 50% with cost savings, but it was also the smallest number of CTIs with only 4. Care transitions and primary care, which were the 2 largest thematic areas, had 31% and 36% with savings respectively. Okay, looking again at the total target costs minus the total performance costs, this visual is intended to show the distribution where above 0 are CTIs that saved money overall. So the performance costs came in below the target costs, whereas those below zero, the performance costs were greater than the target costs. And then the size of the circle represents the total number of episodes. So we can see here that there was quite a range in the size of the CTI or the number of episodes across the thematic areas, but there wasn't necessarily a correlation between the number of episodes and the total costs savings. This is another visualization that looks at per episode costs and compares target per episode cost and performance per episode costs, again, by number of episodes. We see that overall primary care came closest to target costs, target per episode costs, with primary care having an average per episode cost within 2,500 of the average target per episode cost. Care transitions had the widest variation, with one CTI that was over $35,000 over the per episode target costs, and another was more than $16,000 under the episode target costs. And this could be due to the fact that the care transition CTIs were composed of a wider variety of different interventions. And according to some of our key informant interview responses, we're more likely to involve coordination with external stakeholders, which could mean that some aspects of the intervention were outside of the hospital's control. Another key finding we had was that many CTIs had a low number of total episodes, and the majority of CTIs had fewer episodes during the performance year than in the baseline period. In fact, the only thematic area that had more episodes on average in the performance year than the baseline period was primary care. We can see here the table has the different thematic areas, and the third and fourth column represent the median and the mean across CTIs within each thematic area, and the difference in the number of episodes between the performance year and the baseline period. Again, this could be due to lower overall healthcare utilization because of the in some of these thematic areas due to the COVID-19 pandemic, or it also may be due to issues with the CTI inclusion criteria that some hospitals decided to choose. We see, though, that CTIs with a low number of episodes are unlikely to generate significant total cost savings just because of limited patient volume. So even if there is a CTI that has on a per episode basis savings, if there's not a high patient volume, then we will not see the large cost savings overall. Our final quantitative analysis focused on social determinants of health. And we actually see that on average, CTIs with a social determinants of health focus averaged better, on average performed better than CTIs did not have the SDOH focus. We see that 4 of the 5 thematic area CTIs that were described as having an SDOH focus had on average lower total costs and less losses than CTIs without this focus. So this table shows the number of CTIs by thematic area with a social determinants of health focus, and the average savings and total costs. Based on our survey and interview results, we see that the CTI design and implementation were driven by participating hospital strengths. The majority of survey respondents said that overall their implementation of the CTI was a positive or somewhat positive experience. And the responses indicated that successful CTIs were developed by hospitals with existing programs that could be implemented as part of the CTI program. So we saw that many hospitals, for example, were able to implement parts of their MD PCP program as a primary care thematic area. So CTIs that were already implemented in one form or another within a hospital, hospitals tended to view those CTIs as being easier to implement and more successful overall. There were several challenges that were identified based on the survey and interview results. Majority of the survey respondents mentioned challenges in identifying and capturing the intended patient population using their data. So many hospitals reported a small number of episodes as a challenge, or if not small, then less episodes than expected as an ongoing challenge in the program. Many survey respondents mentioned COVID-19 as a challenge, specifically around the labor and workforce shortages that this created. Data lag was a common challenge mentioned just due to the nature of the program. There could be a several month lag in data being updated on the CRISP portal, and this made it difficult to quickly modify underperforming CTIs, although some CTI participants were able to develop their own internal metrics in order to get a more up-to-date look at their CTI performance. And then the CRISP, CRISP data clarity and filtering options. Many participants indicated that they found the CRISP portal to be helpful, but not all had the resources or the expertise needed to drill down to patient level data, specifically to identify which specific episodes were being included in their CTI. As far as future changes that participants would like to see in the program, several participants mentioned additional support from the state. In general, interviewees praised CRISP for its responsiveness to questions and suggestions, saying that they definitely felt heard by CRISP throughout the program. Some respondents did feel that the HSCRC could improve their responsiveness, and especially around some of the frequent program and methodology changes that occurred during the first year of the program. Many participants expressed some issues with the cost methodology. They mentioned that the cost methodology is very complex, and there's a desire to more clearly see the calculations, specifically around CTI target price and the total savings. And sharing best practices. Every interviewee that we met with said that it would be helpful to connect with other CTI participants on CTI related topics. There is an emphasis on hearing from success stories from specific CTIs that were found to be overall successful. So in conclusion, we found that hospitals in Maryland are committed to quality improvement and motivated by the CTI financial incentives, but many may require ongoing technical assistance, designing episodes and understanding the methodology. CTIs with a large number of episodes and performance costs below target are necessary for generating significant savings. So any CTIs that have a smaller number of episodes, even if they are showing performance costs below target, may just not be may not be worth pursuing in the long run, just due to the low amount of overall savings that could be generated. Hospitals are seeking up-to-date detailed data to analyze program effectiveness. We noted that many hospitals are relying on up-to-date data to kind of evaluate their CTI in real time and potentially make changes in the current year for future years. And finally, CTI participants would like Chris to facilitate more hospital collaboration to share best practices. So that concludes our presentation for our prepared content, but we're happy to answer any questions if you have any.
Thank you so much, Max. We really appreciate that overview, and I think this evaluation has been very meaningful. I do want to make two comments. One, that the HSCRC obviously was greatly involved in this evaluation and was able to read the preliminary report. They actually have the intention of using this evaluation and feedback to guide their agenda for the next couple CTI steering committee meetings. So they will be focusing on areas that some of the survey results identified as areas of concerns or for improvements, and they will sort of continue that conversation. I think that's actually it. So I will move on to questions. I only see one in the chat, but feel free to continue adding them to the chat or take yourself off mute. Laura, you did ask, was anything done to control for COVID for episodes that were not tagged with a primary diagnosis? I'm assuming this is a little bit more related to the policy side, since AIR and Max kind of only were dealt with or only were given the data or the results from the program. So I do want to comment that, hopefully not getting out of my wheelhouse from the policy standpoint, but that beneficiaries that are diagnosed with COVID are excluded. That's sort of the default filtering from eligibility into the CTI. Hospitals can request to include them as, you know, one of their filtering options when building their own CTI, but as default, those bennies are actually excluded from CTIs. So hopefully that answered a little bit. The next one, so Max, there's a question about how did you define CTIs that you categorized that had an SDOH focus?
Yeah, it's a good question. So we received descriptive data from CRISP on each CTI. I will note that it was not super detailed into specific interventions, but hospitals were able to, within the description that we received, note if there was a social determinants of health focus. So if a hospital sort of self-identified as their CTI or a specific CTI having an SDOH focus, then that's how we counted that. So there could have been CTIs that either targeted population that had an SDOH focus, or enough, sufficient detail was not provided to us to include it. So there could be certain CTIs that kind of were miscategorized in that part of the analysis, but we did our best to, based on the descriptions that we received, categorize CTIs by SDOH focus or not.
Thanks. And I think that brings up a kind of good discussion point as far as when hospitals or participants actually create their CTI within the portal. There is that large sort of free text field for people to put in their description. I'm sure Max can comment, but the level of detail in that is quite a range. So I think as we look for opportunities to have collaboration for shared or for similar CTIs, that may be a option for hospitals to sort of initially put in some information so we can group things together and just ensure that we're sort of honing in on our approach to the collaboration. Laura, I see you have your hand up.
Yes, thank you. So I want to make sure I'm getting one of the key takeaways right here. You reported that the mean total cost in excess of total targets was over 1 million. So this means across all episodes, generally they exceeded their target price. That would be one question of clarification. And then two, I'm wondering, overall, are we showing a savings regardless of, the policy states that only positive savings are accounted towards, state rewards?
So the answer to your first question, that number, the 1 million, is not a per episode. Sorry. Let's see. That it's not a per episode number, it's a total. So on average across all CTIs, the total costs exceeded the target total costs by 1 million. That does mean that on average, also on a per episode, the performance exceeded the target, but I don't have that specific number in front of me right now, if that's helpful.
Thank you.
And I'm not sure I understand your second question. Could you repeat it?
Yeah, and this might have more to do with the policy implementation, which I understand wasn't included in your evaluation. So under the policy, any, hospitals that generate savings are rewarded those savings, and then any savings aren't counted. I'm wondering, regardless of that, did the a program in fact show a savings?
So I can jump in here. Yeah, I don't think just given the data that was available at the time for this, that we felt comfortable for them to make that conclusion, since it's based off of the total performance of the state as well. It's sort of the individual CTI's performance against how did the state do to make that calculation. So we will be able to know that in about a month when they have the final data in, and I'm sure the HSCRC will report on that. But I don't think, Max, there was anything that you all could have pulled from that at this time.
Okay, thank you.
Are there any other questions? Okay, well, I do want to thank everyone for their time today, and thank you, Max and AIR. Been wonderful sort of partners as we've continued, these different analyses questions. Again, I do want to highlight that their continuing conversation about the CTI will occur in the CTI steering committee. The next one is in April. And additionally, Chris is hosting 2 webinars. They'll cover the same information. 2 webinars about the enrollment process and the enhancements that were made to the character information profiler. The first one is on Tuesday, April 11th, apologies. And then I believe the next one is that last week in April. Shoot, sorry, I don't have the date on top of me, but it is all posted on our learning system, and hopefully you guys also did get an email about it, but feel free to reach out if there are any questions about that. And we, like I said, really look forward to kind of having fruitful conversation from these conclusions and evaluations. So thank you all, appreciate it.